Ladies and gentlemen, and anybody out there watching, my name is Mark Drax. Welcome back to another Sex Byte interview. Today, I have the great pleasure of being here on screen with Dr. Erin-Lee Kelly. On my left screen, I can tell you that she is a university lecturer. She's a featured speaker. You're a researcher. Erin, a very warm welcome.
Thank you very much. I appreciate being here. It's
lovely to have you, Erin. Thank you for your time. You are very kindly going to be speaking at our conference, which is, the weeks are rolling by. I mean, I think we're 6 weeks out now, which is very exciting.
Very soon.
Your topic this year is called clashing consciousness. So I'm going to kick off with a question, if I can. Erin, tell us about clashing consciousness.
Sure. So, I really want to open the door to self-inquiry about taboo topics around sexuality. That is kind of my goal. So much of the counseling professionals experience counter-transference, and we're all aware of counter-transference is what, emotions that are elicited by your client, that something comes up in you. And it's essential it's essential graduate training topic that everybody works through typically. But unfortunately, around sexuality topics, that is not the case, especially topics that can start a little bit of fire in you and you don't understand it, or you don't quite want to understand it or have the desire to. What do we do with that? What do we do with ourselves? So the foundation of sophisticated psychotherapy is really understanding your emotional reactions to clients. And this is going to be around topics that are difficult.
So, Erin, could you just, for people out there that may be watching this, because not everybody may be too familiar with the exact simple definition of counter-transference. Could you just set that tone for us?
So counter-transference is the reaction that so there's transference and counter-transference. So counter-transference is the reaction that the clinician has to a client's emotional reaction, response, anything that comes up in the therapy session that might trigger something in the clinician themselves. So, for example, if you have some alcohol abuse in your family, maybe a grandparent or an aunt or uncle, and then your client sitting in front of you, and they say, "Oh, I drink to excess. I drink to blacking out." That is going to stir something up in you because you have an emotional reaction to that. That is what we consider countertransference. So it's something that the client is imposing on you without you even recognizing it at first.
And thank you. That's wonderfully clear. And of course, you've used the example of an alcoholic topic triggering something. But of course, what we're talking about today is sexual issues, which of course carry even more stigma, even more fear. So tell us more about that and more how it specifically relates to what you're going to be talking about.
Sure, absolutely. So during my research, I found that many graduate programs, when it comes to counseling and psychology and licensure laws, don't really address specific sexuality learning objectives. So typically programs omit discussing difficult topics, really difficult topics. And what I mean by that, excuse me, is like minor attraction, also known as pedophilia, but there's nuances I won't get into right now. Understanding that, pornography, sex work, polyamory, infidelity, all these topics that we are aware of, but many times not adequately addressed in training programs. And clinicians are confronted with this on a regular basis, but unfortunately, they don't know how to manage that when it comes up. And if you don't manage that emotional response, then you're doing harm. You're having harmful responses to the client, intentional or unintentional. They are going to suffer for that, and so is the therapeutic relationship.
Correct me if I'm wrong, Erin, but what this could lead to is judgment. Because, I have in my time had, and maybe you have too, sadly, I've come across a limited number of people who have been involved in sourcing illegal pornography, etc. I would be pretty useless to my client if, when that came up, I sat here, had a major judgment attack, and my whole tone changed to one of anger or dismissal. I'm not exactly going to be very useful to my client. Is that the kind of thing we're talking about here?
Absolutely. That's a great example. For example, if you struggle with, maybe a parent or a caregiver had an affair on your other parent, and then all of a sudden the client comes in and is like, well, yeah, I sleep around on my wife or my husband. That's going to, again, elicit some emotional response that may be very angry, very dismissive, judgmental, biased. And then that's a topic that we're familiar with. But then you add something like sex work or minor attraction or pedophilia or child pornography. So then what do you do? How do you manage that? And that's really what my workshop's about, is really how to manage that. And I have a toolkit I can offer to process that, those feelings that you have.
That's awesome. So just off the cuff, give us a little flavor of the type of advice you might find yourself giving a fellow clinician as to how to better embrace this whole topic.
Right. So during my research, I found that some that I guess recommendations were new and very valuable versus the ones that were more conventional. Conventional is talk to your supervisor, talk to a colleague. But what's really interesting is you can actually get there's so much wealth of information and value out there, finding groups that specifically work with different populations and learning from those groups. So during my research, the young clinicians, they were on Facebook groups and social media groups that facilitated conversations back and forth with people who actually that's their specialty. And it's interesting because I think a lot of people do like to share their knowledge and do like to share, like, oh yeah, I work with, offenders that are interested in child pornography. Let's talk about this. Let me tell you what I know. So that conversation is, and the dialogue is really there, and to use that. Don't be afraid to ask. Don't be afraid to say, I don't know. I need help with that.
That makes perfect sense. If we bring this into the realm, because as you know, SASH stands for the Society for the Advancement of Sexual Health. How would you see this being particularly important to sexual health?
Right. So we, a lot of what we're familiar with is sexual dysfunction, and we aren't very familiar with healthy sexuality. And that is something that is hopefully that paradigm is going to shift when it comes to clinicians trying to understand their clients. So not to focus on the dysfunction, but actually focusing on what's healthy. So, I introduced something called the Circles of Sexuality by Dennis Daly. It gives a great synopsis of the person's sexuality, understanding each element and how they interact and with the person's value system. I will also address your sexological worldview, how to understand how to explore your sexological worldview. And through that process, with the counter-transference management techniques that exist already, you should be quite prepared to take on then something that you might have an adverse reaction to initially, to actually be more comfortable and secure in managing something that you are uncomfortable with right now.
You're making it very clear why all practitioners, especially in this field, need to have an understanding of this fascinating topic. Tell me, in your experience, what other influences have you come across that play a part in this whole arena? And one that comes to mind for me might be religion. How does what external influences have you noticed that crop up to add to these challenges?
So absolutely, religion. So if you think of now what you're asking is part of the bigger sexological worldview, and exploring that is understanding, not just your spirituality, culture, knowledge, education, beliefs, attitude, sexual behaviors, relationships. This is all part of your sexological worldview, which Dr. Dyson and Dr. Citron created this concept of sexological worldview, and a lot of their research is based on this, of understanding all the elements and how they create your sexological worldview. So yes, spirituality is part of that. Like your spirituality, your religion, your beliefs around that can dictate how you respond to somebody and a client. And you have to be mindful of that process. Doesn't mean you have to change your worldview. I think the most harm you can do is to expect their worldview, your client's worldview, to change based off of yours, right? So you have to understand theirs, you have yours, and that is how you have a positive therapeutic relationship and change can occur.
Well, that's an amazing statement you've made, because correct me if I'm wrong, I'm going to tread lightly here, because this could open a big can of worms. But what you've just fundamentally said describes pretty much the source of most wars on planet Earth. You tend to have one religion trying to force another one to behave in the way the first religion thinks it's right to behave. So that's just religion. I would say just religion is the thing that pretty much makes most of the world tick. And then you add in sex, you've got quite a big melting pot here.
Yes, worldview converting is probably one of the most harmful things you can do, because you don't understand, the other side, or the other, the other person's understanding of their worldview. And I think as clinicians, this is our job to do that. Well,
not only if we not understand it, sometimes I think, correct me if I'm wrong, but even greater harm can be done if you don't want to understand it, if you're not curious enough to remain open-minded enough to even try to understand somebody else's point of view.
Right. And I think with my topic or my workshop, there's many clinicians out there that say, like, I absolutely will not work with sex offenders. I will not work with somebody who is a sex worker. And you have the right to do that. You want to make sure that you know your limitations. But I just want to prepare that it will come up. Counter-transference happens in every situation for every clinician at some point in their career, that you are prepared if and when it does happen.
Yeah. It's funny, I'm remembering an extraordinary example. This isn't so much, it's when you say, I've heard people say, I wouldn't work with such and such too. I remember doing an internship at a well-known treatment center in America. And I arrived and I met the clients who one of whom I was going to be allocated to. And one of the clients on the first afternoon had tragically suffered throat cancer and could hardly speak. And out of the half dozen clients, and there were several of us interns, I thought, oh my God, please don't let me get stuck with the guy that can't speak. Well, guess who I ended up shadowing for a week? And I learned more from that blessed man than I've ever learned from most people who can speak perfect English. So it shows I had to learn to open my heart, not judge, not let a stereotype affect me, not let a massive impediment affect me, and just listen and open my heart. And of course, the fact that I had to really listen actually meant I probably learned a hell of a lot more than if this guy could just banter off in a normal tone.
Absolutely. Absolutely. It's a great example.
And looking back, Erin, through we've had over 2 years of a global pandemic, and I'm not going to go into the whys and wherefores, but because it's been talked out. But have you noticed anything that has changed through your work around the specific field? Countertransference, has anything come out of the pandemic which has changed this aspect, has become more extreme, has fallen away? Anything that does relate to the last 2 years of all our lives in particular?
Not necessarily around countertransference that I have picked up. What I've noticed is pure exhaustion, vicarious trauma through, just being burned out. A lot of clinicians have taken on so much, but the only difference that I do see, or how I can answer that question, is that, again, clinicians are reaching out to other clinicians. So now we are almost all online. Very few of us are in person, or not as much. And we're very quick to actually connect to other people online to answer these questions. Hey, I don't know this. And we're more familiar. Whereas back, a couple of years ago, you sit in your office and you see your clients and you're too tired to open your computer up and ask somebody what's going on over, for this topic or that topic. Now, I think people are very quick to do that and they're more comfortable being online. So, they are addressing this differently.
So actually, that's one of the loveliest answers I've had to any question, even close to the one I just asked, because that talks to a benefit, a positive outcome from a global pandemic. Yeah, you're right. 2.5 years ago, nobody heard of Zoom. At least very few people had. Now, people we're talking on Zoom right now. We're conducting a fabulously fun interview. You're in America, I'm in England. So yeah, the pandemic has changed it. Forced us to change the way we communicate. And yeah, I think it's brought from one perspective, ironically, it's brought us closer together.
Right. It's so much easier for us to connect rather than try to meet in person. And so you're more quickly to answer things.
Well, it's also a hell of a lot cheaper. Yeah, I haven't got to get on a plane to come and interview you.
Right.
Anything coming up in the near future that you would like people to know about you? Sell yourself for a second. Have some fun.
Yeah. Okay. Clinicians aren't really good at that. A lot of them aren't. It's usually about other people. So I appreciate that. No, I'm looking forward to continuing my research on this. I unlike a lot of people, I love the topics that people don't want to talk about. I like to talk about religion, politics, and sex. So if we can be more comfortable and we open the door to these conversations across the board with families, with friends, and not be too scared to have these conversations, I think all of us would be better off and we'd have less dysfunction in this world. So all I'm going to plug in is keep communication open. Don't shut it down and keep talking to each other about a variety of different issues. It's really important.
Erin, your topic is massively important. You and I both, I'm sure, experienced this in our past. I have a strong suspicion you've been doing this a lot longer than me. I started in this field as a professional in January 2013. I have a hunch you're a little longer in the tooth than me. But we've both been there. We've both experienced this. And give us one final takeaway, something along the lines of why you feel every professional should come to your presentation.
You never stop growing. You never stop learning. And if this is going to help you come out of your comfort zone, because that's really where the work begins. As we teach our clients, let's practice what we preach.
Getting out of your comfort zone. Erin, it has been a fantastic privilege to talk to you. You're a very busy lady, so I'm enormously grateful. Erin is going to be talking at our conference in the middle of October in Atlanta. Please come and listen to her. But Erin, for today, for your time, for your expertise, a massive thank you from me on behalf of SASH. And at some point, I do look forward to meeting you in the future.
Thank you. Appreciate that.
Erin, take great care. Good luck in all you do.
Thank you very much.
Thanks, Erin. Bye-bye for now.
Bye-bye.